Any questions about any of the other stuff we've covered for the test, like GI, the room stuff, orthopedic stuff, pain management, anything? Everyone's an expert, and they're gonna just wreck this Kahoot. Something fierce. Right? You guys are done with the week. You can't, it's only Thursday. Do you guys have peds tomorrow? Is that your test?
Oh, we sure do.
Oh boy. That's why I'm sensing a little disengagement from the group. How many slides do you have to review?
Only like a minute. It's not so much the number of slides, but the number of pages that she has copied and pasted personally.
No, I don't believe anyone's ever done that in the history of faculty. But there's a lot of information. Turns out pediatrics is pretty complicated. All right, let's go ahead and get started here. All right, 23 questions, if you're ready. Which medication for rheumatoid arthritis works by inhibiting the Janus Kinase proteins? Would it be methotrexate, tofacitinib, etanercept, or tocilizumab? What do we think? It's good to know your mechanisms, right? Because you need to know if you need to switch a medication, which one to go to. Yes, sir. How do I do that? Oh, the window up. Okay. Let me try that. You guys are getting... Is that better, do you think? Yes, okay. In the middle of the... That'll work. Okay. Yes, this is tofacitinib, would be the JAK protein inhibitor, right? So again, it's one of those tyrosine kinase inhibitors, essentially, where by doing that, again, very, very potent anti-rheumatic sort of actions there. We still consider it to be pretty immunosuppressive by inhibiting proliferation of those T cells and things like that. How does methotrexate work? Folic acid antagonist, right? Good. Tocilizumab, how does that one work? That one's going to bind up IL-6, right? Interleukin 6 is that one is going to bind up that one. How about etanercept? That one's going to be TNF, right? So again, remember which ones are which, because if I say, hey, patient failed, say methotrexate, or I'm sorry, failed like infliximab, which one do you want to switch them to? And if I gave you another TNF alpha inhibitor, that wouldn't necessarily be a good option there, right? You want to switch over to something with a different mechanism, something like tocilizumab, IL-6 inhibitor, right? That might be, you get better bang for your buck from that standpoint, right? It's good to know what to combine together as well. So could I do a combination of etanercept plus tofacitinib? Would not want to do that because you see too much immunosuppression. Could I do methotrexate plus tocilizumab? I could do that combination, right? So I can use a non-biologic plus a biologic. I can't use two biologics together. You can't use tofacitinib with any of the other biologics, okay? Good rule of thumb there. What do I need to test for before I give something like infliximab? Yep, TB. Fantastic. All right, patient misses 3 doses of her oral contraceptive. How should she get back on schedule? She take 1 extra pill for 3 days and continue as normal. Take 3 pills today and continue as normal. Take the whole pack at once and restart next Sunday. Or discontinue the rest of the pack and start a new one on Sunday. What do you think? Just take the whole pack, maybe. What do we think? Yes, if you miss more than 2 days, they recommend go ahead and just discontinuing the rest of the pack. If you're using backup contraception, and then get started on a new Sunday. Does it have to be Sunday? Nope, doesn't really matter, right? So if they work on the weekends and they want to have it on the weekend, withdrawal on the weekend, that's totally fine, right? That does not really matter. It's just a typical thing done for a good long time. They miss 2 days. What can you do? Take 2 pills for 2 days, right? Again, when you have big doses of estrogens coming in, nausea vomiting is going to be a concern there, right? So again, we saw that especially with progestins when we saw like the Plan B, right? So just know nausea vomiting is going to be more common when you get these bigger doses thereof, right? Would not recommend taking the whole pack. Would you necessarily see like a lot of overdose sort of effects? And would it be dangerous? I really wouldn't worry about that one, right? Okay. A person with acute pain after a dental procedure would most benefit from which medication? From hydrocodone acetaminophen, from heroin IV, fentanyl patch transdermal, or oxycodone extended release PO? What do we think? Bless you. Seems like everyone is sick around here these days, it seems like. It's almost like being chronically stressed and your cortisol levels through the roof mildly immunosuppresses you and it makes you more susceptible to viral infections. Weird. Yeah, so we're looking at acute pain, right? How we're going to be managing this, right? So for instance, why would transdermal fentanyl be a bad option? You could put it in your mouth. You get a whole lot of fentanyl all at once. You'd probably die. You wouldn't want to do that. Why would you not want to use transdermal fentanyl as intended? It takes too long, right? It would take too long to kick in, at least like a day or so before you really start to see the drug level start to pick up. Why not extended release oxycodone? Yeah, they don't need extended release products, right? It's an acute pain issue. You need to start off with immediate release products, right? When I post up my video of that talk that I gave last weekend, you will see exactly that point being made there too. Heroin IV, would that work? Heck yeah, it would work. Maybe feeling great, but not recommended typically, right? What schedule is heroin? Schedule? It's a 4 or 5 schedule. I schedule it 3 times. No, schedule 1, right? There's no acceptable medical use for heroin. I do not recommend it. Yeah, so hydrocodone acetaminophen, a nice short-acting or immediate-acting sort of product is going to be preferred there for acute pain issues, right? What's the most day supply you could write for if you're writing a patient a script for Lortab? If I did 7 days, what do I need to put on that prescription? Acute pain exemption. Okay. Actually, I had one PA who came up to me after that talk and he said, yeah, my pharmacist, is it exemption or is it exception? The law says exemption, but the pharmacist he was dealing with was giving the PA a hard time because they wanted to see exception. Does it really matter? Probably not, right? As long as I wrote something on there. You will find that some pharmacists are very persnickety, especially when it comes to controlled substances, because they don't want to get in trouble for it. So again, sometimes you need to take the law and read it back to them and be like, actually, this is what it says. And then sometimes they will listen to you. Other times they will just say, I'm just not going to do it. And then that's inappropriate. But anyway, I'm kind of a self-loathing sort of pharmacist. I actually don't like a whole lot of the pharmacists I know. So my wife is the one notable exception to that. I do like her quite a lot. Okay. Mesalamine enemas would most likely benefit which patient? Be ulcerative colitis patients, patients with Crohn's disease, GERD patients, or constipated patients. What do we use mesalamine for? What would be good for? All right, let's look at this. So, Rowasa, how does it work? What does it do? What do you notice about the last 3 letters of the brand name? ASA? Yeah, it's basically like aspirin, right? It's aminosalicylic acid, essentially. It kind of has those similar activities there. So, again, anti-inflammatory, right? Now, it's an enema, so how far could it potentially get through the colon? Yeah, it'll kind of get there, but the furthest it's going to get is really not past the splenic flexure, right? It's not going to be able to get past there, right? The gravity or just the volume is not going to be enough to really get past there. So this is good for like proctitis associated with ulcerative colitis. Not good for Crohn's, because why? Too diffuse, right? So again, you're not going to be able to get nearly far enough in order to treat those areas there. Obviously not used for constipation, not used for GERD. We do use enemas for constipation. What sort of enemas would we use? There's some options. Usually it's hyperosmotic solutions with things like sodium phosphate, right? So you see a Fleet's enema that is Sodium phosphate-based enemas there, right? So again, getting really hyperosmotic fluid into the rectum is going to stimulate a lot of that fluid input. It's going to stimulate that stretch receptors, and say, hey, we need to get all this stool out of here. You could also use stimulant laxatives potentially, so like bisacodal comes as an enema. So there's different options that are out there. Mineral oil could be used as an enema. What does mineral oil do to the stool? It's going to lubricate it and get them a little bit more emulsified and make it easier to pass, right? So there's different options you have there, but typically sodium phosphate enemas are the most common ones you run into. You could use subsuds enemas. We don't recommend that too frequently now because there's some concern of electrolyte disturbances with that, but just things to consider. All right, moving on. Colchicine or Calcrys would be best suited for patients with gouty arthritis, osteoarthritis, rheumatoid arthritis, or osteoporosis. Does anyone know what plant that is? It's where we get colchicine from. It's actually the autumn crocus. So again, allow your friends and family with your pharmacy trivia knowledge. Yes, gouty arthritis. Oh, yes, sir. No, I pick up the most needless details, and actually the important stuff I just can't keep in my mind for it to save me. So, no, it's actually we learned as part of my fellowship in toxicology. You know, like where a lot of these plants come from, because if a kid were to accidentally ingest one of this, we need to know what kind of plant was it, what type of exposure could it be. You know, a lot of plants are very safe if they were ingested by a child or an animal or something like that, but some of them can be pretty darn deadly, right? So, colchicine can be one of those. Yeah. Anyway, so yeah, so we use this for gout. Now, this would be good for prevention of gout or for acute treatment of gout. Good for acute treatment, right? So again, it's going to be help. And how does it work? Disrupts those microtubules, right? So it's going to be able to basically inhibit things that leukocyte, locomotion to the site of inflammation, things like that. So very good from that standpoint. For acute treatment, not necessarily good for long-term prevention. I'm starting to see some people who will take it every single day. However, I don't know there's as much evidence for that use. Classically, though, colchicine is good for acute treatment. Obviously not used for osteoarthritis or any of these other ones here. Okay. What is the max allowable acetaminophen in a day for a patient receiving hydrocodone acetaminophen? Is it 3,250 milligrams? Is it 500 micrograms, 4,000 milligrams, or 1,200 micrograms? All right, so the acetaminophen limit doesn't change depending on what drug they're receiving there, right? So again, if they're getting oxycodone acetaminophen, 4-gram limit is still going to be in place there. If they're a patient with like chronic hepatic issues, then you wouldn't want to use a lower dose, right? Usually 3250 is what they'll recommend for patients with chronic hepatic disease. That's a big thing to consider. And again, think of all sources of what they're getting, right? Because they can get acetaminophen over the counter, they can dose themselves with that while taking this in conjunction. So it's really important they're considering all sources and not to go by that 4-gram limit there, right? Does anyone know what dose of acetaminophen you get in things like Percocet or Lortab? Now it's, well, so that's the, yeah, so and it's good to note there which dose is what. So if you see 5 or 10 or 7.5, that's the dose of the opioid, right? So oxycodone or hydrocodone. It used to be 500, now it is all 325. And again, why do we make that change? We get too many patients who are taking way too much of this stuff in addition to other forms of acetaminophen. We saw a lot of hepatotoxicity with that, right? So because of that, they decided let's go ahead and just drop all the doses there of the acetaminophen into 325 essentially, right? So that's the only what you're going to find there. What can be given to patients when receiving infliximab or Remicade to prevent infusion reactions? Diphenhydramine, epinephrine, methotrexate, or adalimumab. Very good. So again, we're thinking about things we can give before they have a reaction in order to manage that, right? So again, this is called pre-treatment before they have a reaction, because again, a lot of people are going to have reactions to infliximab because it's got all that mouse protein in it. You're going to have a reaction to it. What else can I give as a pre-treatment as well? Yeah, some people get steroids, so we'll do like a big dose of steroids right beforehand. What else? Well, like the myalgia, some kind of usually acetaminophen is what we'll end up giving. Yeah, so again, if they're having kind of flu-like symptoms, a little bit of fever, myalgia, we'll give the acetaminophen as a pre-treatment as well. Some patients will get all three. Some of them only get one or two. It just depends on the patient, what reaction they've had to it beforehand. But with infliximab being more likely to see that, you give generally a lot more of the pre-treatment versus something like adalimumab or Humira. It's a humanized protein, so because of that, we have a lot lower risk of having infusion reactions. In fact, it comes as a sub-Q pen, essentially, where patients take it home. Infliximab, you have to get in like an infusion center or something like that. It has to be infused IV because of that reaction risk. Now, epinephrine, when would you give that? Well, yeah, once they're actually having the reaction itself. So again, you would never use epinephrine as pre-treatment. Otherwise, your patient is going to feel very uncomfortable, hypertensive, or stroke out. No good, right? You don't want to do that. The methotrexate, would I ever use that in conjunction with infliximab? Not as pre-treatment, but yeah, sometimes you might actually use those two together. One, to get better synergy for treating something like rheumatoid arthritis, but also because your body will eventually develop some degree of antibodies against the infliximab, you can actually use the methotrexate to help prevent those antibodies from being formed, right? And either neutralizing the infliximab or potentially causing the anaphylactic reaction. So sometimes you'll see some additional benefit there. All right. Which of the following products would be contraindicated in a 16-year-old female with no past medical history? It would be spironolactone, medroxyprogesterone, ethanol estradiol, or raloxifene. Contraindicated, a 16-year-old female, no past medical history. Pretty big split there. Why would she be contraindicated from receiving ethanol estradiol? Because it's by itself, right? You cannot give estrogens by itself to women who have an intact uterus because you worry about the endometrial cancer risk. Very good. Medroxyprogesterone, could you receive that? 100%, yeah, absolutely. They can use that for long-term prevention, pregnancy. It's a depot shot, essentially, right? Spironolactone, when would we use that in a 16-year-old female? Yeah, sometimes for acne. Why? Anti-androgen, right? It will block activities of testosterone, which increases things like estrogen production, etc. So you may see some younger females on spironolactone. It's not because they have CHF; it's because they have acne potentially, right? All right. Which agent would not be used in the treatment of H. pylori infection? Again, no negative questions on the test, but here I can get away with it. So, would I not want to use bismuth subsalicylate? Would I not use alginic acid, omeprazole, or amoxicillin? I like this picture because a little bacteria, H. pylori, kind of looks like the heptapods from that movie, The Arrival. Oh yes, alginic acid is not a component of treatment for H. pylori, right? So you typically have a 3 or 4 drug regimen. What goes into that regimen? The baseline, you get a PPI, and what else? 2 antibiotics, such as amoxicillin, clarithromycin, Cipro could potentially be used, Cipro. Metronidazole is another good one, right? Yeah, so usually a combination of 2 antibiotics plus a PPI. That's a 3-drug regimen. You do the 4-drug regimen, what do you add on? Bismuth, right? So that's when you get the Pepto-Bismol added on to there. Okay, good. Alginic acid, it'll when it combines with stomach acid, it'll kind of help to coat the stomach pretty well there, but not a component of H. pylori treatment. Okay, so good to know the different components there. What's the benefit of using a 4-drug regimen versus 3? You got more drugs equals better. Quicker recovery, and you're more likely to get eradication of the H. pylori. They found better treatment, better cure rates when you use a 4-drug regimen versus a 3. Okay. Who would be contraindicated from receiving bismuth subsalicylate? Kids less than 16 who are post-viral, right? Because you worry about what risk? Raised risk. Fantastic. Control studies in women failed to demonstrate risk to fetus during pregnancy. Which pregnancy category would that be? So controlled trials in women failed to demonstrate risk to the fetus during pregnancy would be B, D, C, or A? know it's confusing, but I randomize the answers. If you have a question like that on the test, it'll probably also be randomized and will look kind of funny. But. Fantastic. Yeah, so again, if we have good evidence from actual studies to show us there's no harm to the fetus, and then that gets classified as a category A, right? Category B would be what? We have pretty good evidence that it doesn't have any harm for the fetus. Even if we have animal studies that show there's some harm to the animal, we have good evidence for humans that there's no issues there, right? So it's pretty good. I feel very comfortable giving a female patient who's pregnant a category B drug. However, when you get into the C category, you're like, I don't know, like, we don't have really good evidence to show one way or the other. We can't do the studies because it's not ethical to give pregnant patients a bunch of drugs and see how their baby turns out, right? So again, that's kind of the kitchen sink kind of, or kitchen drawer kind of phenomenon there with that one. All the drugs are going to be lumped into that. A D category would be what? Almost never. When would I? Yeah, there's a potential risk to the mom such that she may have maternal demise, because if you have maternal demise, you have fetal demise as well. So there may be some rare instances there. But again, I would never recommend unless I absolutely had to. And the category X is never. What's a good example of a category X drug? Accutane, right? Because again, the risk is there. We know it. And again, it's not a life-threatening condition, acne, so we can go without treating it for that pregnancy. Okay. Very good. Which of the following is true regarding medical marijuana? Short-term memory loss is a potential side effect. Oral administration is the fastest onset. It may only be prescribed for indications supported by randomized controlled trials, or weight loss is a common side effect. Yes. I'm glad you all, really some of you remembered that, right? Anyway, yeah, so you can have short-term memory loss, potential side effect, right? What are some other common things you see? Some drowsiness, have appetite stimulation, so weight loss usually isn't something you see with that. And again, that's a benefit for some patients, especially if they have like, cancer and being treated for that, and they normally have a whole lot of appetite. It's good for, muscle wasting conditions, things like that would be good. What other things would you be worried about someone exposed to marijuana? Having coordination, should they get behind the wheel of a car? Probably not, right? Those are the big ones, right? Relatively very safe though. What if they were inhaling it? What could I be worried about? Say it again? Yeah, so again, if they have like reactive airway disease, or if they have, definitely if they're, using chronically for many years, you see the same damage done because that hot smoke, damages that epithelia in the respiratory tract, just like smoking a cigarette would, right? So you can't see long-term issues there. Again, who knows what the long-term effects of like vaping is going to be, as we'll see. Some of the extra ingredients they're adding into there, is that going to have long-term effects? We don't know. But again, usually that when vaping, like that gas is a lot less heated than you would see for like something you're smoking a joint or something. Oral administration obviously does not have the fastest onset. It can be very slow. How long do you want to give it before you consider whether or not it's really kicking in? Hour, 90 minutes or so, right? So again, fairly slow onset. Again, we worry about people dose stacking. When they get 30 minutes in, they're like, I'm not feeling anything, let me take some more. And they get into big trouble that way, right? All right. Which medication blocks sodium channels to prevent neuronal transmission of pain signals? The buprenorphine, lidocaine, naloxone, or capsaicin? Very good. Lidocaine. Lidocaine is, how would you classify that as a drug? Is it 1B antiarrhythmic, but as far as it being used for pain, the local anesthetic, right? So again, it's going to be anesthetizing the area by blocking the sodium channels. You can't propagate that pain signal. up to the brain, right? So you don't stop feeling it essentially. Again, what kind of pain is that good for? Maybe acute pain, right? So again, if I have like a laceration, I need to sew up, I can numb up that area and that can decrease the pain there. What else? Neuropathic pain, absolutely, yeah. So neuropathic pain, if you see like postoperative neuralgias and they have like a lidoderm patch, it's doing the same thing essentially, right? How about buprenorphine? What does that do? The partial opioid agonist, right? What is it normally used for? For addiction, yeah, for helping patients kind of wean them off of opioids. Yeah, so buprenorphine gets used most commonly for that. It's a partial agonist, as I said. Naloxone is opioid antagonist, right? So I'm going to block all the effects of opioids. So we would not use that for pain. And how about capsaicin? It's good for neuropathic pain. How does it work? You rub it on yourself. Yeah, that's true. That's what you do. But how does it work once it's there? It depletes substance P, right? That's what causes all the hot sensation, because that substance P is getting released from those nociceptive fibers. So we have to continue using it, because once you deplete that, then it's working essentially. You have less of those fibers being sensitized. If you stop taking it, substance P levels will build back up, and then it works just and it'll go back right to normal essentially. Okay, that's why you have to tell them take it consistently. The pain will go away. The hot feeling will go away as you deplete that substance P, and it works pretty well. But most people don't stick with it. Okay. First line treatment for gestational diabetes is glyburide, regular insulin, metformin, or dietary modification. I know we haven't talked about endocrine treatment of diabetes. We'll get into that next section, but this one was not made to be very difficult. Yes, dietary modification is the best thing to do, right? So again, if you can kind of get that under control, cut out some of the carbs, that is going to be beneficial. Because again, when dealing with pregnancy, drug exposure is not really preferred, right? Fewer drugs exposed, better, right? You may find some patients may take metformin, very uncommon. Glyburide, we'll talk about these drugs in the endocrine section later on. But typically, if dietary modification alone is not going to work, what do you put them on? Insulin, right? Regular insulin is going to be the best thing, because again, it's exactly what our body's producing anyway. So that's normally what patients will end up being put on. Okay. All right. May not actually be regular insulin. They may put them like on the long-acting insulin or something like that. But insulin would be the next step. Okay. A patient with no insurance and occasional GERD symptoms would most benefit from which agent? Calcium carbonate, rabeprazole, misoprostol, or polyethylene glycol? Very good. Yes, calcium carbonate. Why is that a preferred agent? It's cheap, and what else? Only occasional symptoms, right? These are good for intermittent sort of symptoms, like, hey, if I go out and have a spicy meal, then I get GERD, right? It's only every once in a while. That's when it's good for. Who might it not be good for? Would you want to avoid calcium carbonate in? Say again? Yeah, they're constipated, it's going to worsen that for sure. What else? If they have hypercalcemia already, if they have a history of kidney stones, think about the things where it may not be good to, those in the setting of those comorbid conditions. Rabeprazole is what kind of drug? It's a PPI, right? So it's very potent, being good for more chronic GERD symptoms. Also, it's going to be more expensive, it's prescription only, etc. Misoprostol is what? It's a prostaglandin, good. What is it used for? Remember, prostaglandins stimulate that gastric barrier to be produced, right? That's why we use it in addition to what drugs? To prevent gastric ulcers. What decreases production of prostaglandins? NSAIDs, right? So you give an NSAID plus misoprostol. It's that cytotec we mentioned. They can protect the stomach a little bit better. What else could I use misoprostol for? To help with inducing labor or for abortions potentially, right? So again, several different uses for that because it is a prostaglandin essentially, right? What do you use polyethylene glycol for? For constipation, absolutely, right? So again, do you use it for kind of acute constipation, for more chronic constipation? Use it for both, right? So again, I can give oral polyethylene glycol in very large doses, and that's good for evacuating the entire GI tract, right? Good for bowel prep before surgery or colonoscopy or something like that. Or we can just take it every single day for, just kind of chronic maintenance there and make sure the patient does not become constipated, or to treat, more mild constipation. So again, different options there you have depending on the dose you're receiving there. When I have being used for something like bowel clean out, what brand name does that go by? That's the Go Lightly, right? So again, and the benefit of using polyethylene glycol versus say something like magnesium citrate would be what? Yeah, basically the electrolyte issues, right? So again, I don't have to worry about someone getting hypermagnesiemic or hyponatremic or anything like that with polyethylene glycol because it has electrolytes built into it, so that way you don't really see any shifts there, right? It just basically is osmotic, hyperosmotic, it's going to draw water in, but you don't really see any big electrolyte shifts. Okay, good. That's the main things to consider there. Which agent would allow for the fastest healing of a gastric ulcer? Be cimetidine, magnesium hydroxide, sucralfate, or lansoprazole. I like the 30 seconds better. Keeps things kind of moving along. Fantastic. All right. So cimetidine, what kind of drug is that? H2 blocker, right? Why don't we like that drug? It's CYP3A4 inhibitor. Never, ever, 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 ever recommend cimetidine, or I'll disown you as a PA that I've taught. Because you worry about CYP interactions, and we've got other stuff that works just as well. They're also over the counter. You have no need for cimetidine. Ranitidine, nizatidine, famotidine, any of those are totally fine, right? Magnesium hydroxide is used for what? For constipation, right? You can use it by itself, because again, it's hyperosmotic agent, all that magnesium is going to be able to stimulate defecation. What else? This is a big thing, but you can also see sometimes used for the hydroxide portion of it as an antacid, right? Usually used in combination with aluminum hydroxide. Those two together, where you get like your Malox or Myolanthus and things like that. Usually kind of a really white, chalky sort of liquid. Sucralfate does what? Kind of just coats the stomach, right? So it helps with that. Again, those could be useful for helping to heal the gastric ulcer, but they're going to be relatively short-acting, right? And again, when you increase the pH of the stomach, what does that stomach do to respond to that? Tries to make more acid, right? So you're kind of shooting yourself in the foot. There's limited utility there from sucralfate or magnesium hydroxide. However, cimetidine is going to be pretty good for blocking the activity of histamine on those H2 receptors, and then also lansoprazole, which is a PPI, is going to have the most potent ability to decrease acid production because it's right at the end of the line there, and it's going to have the fastest healing times for those gastric ulcers, right? So you saw shorter treatment periods, several weeks shorter, versus something like an H2 blocker, right? Very good. Which of the following should prompt immediate discontinuation of oral contraceptives? Skin hyperpigmentation, intermittent headaches, breakthrough bleeding, or acute chest pain? Bless you. Yeah, Pete's into Pharm. That's a spicy meatball of a weekend there. At least it's not like a Monday, Wednesday, or something like that. Friday, Monday is a little bit better, right? A little bit. Yes, acute chest pain. What could that be a sign of? Pulmonary embolism, right? Because again, oral contraceptives, the estrogen is going to increase clotting factor production. You worry about DTE, PE occurring there, right? What could be some other things that would prompt immediate discontinuation? If they're tacky, yeah, do that, in conjunction with like the chest pain. Right, so any signs of VTE that could be happening there, right? So again, if you saw like unilateral like leg swelling or palpable cord, all that good stuff, that could show that they got a clot going on there. Now, intermittent headaches, they have like the worst headache of their life, then you could worry about what? That's what you could order. But what could it be indicative of? They're going to say, why are you ordering the CT for this patient? You're going to say, I'm worried about stroke, right? So again, pathognomonic, I think. Yeah, so you worry about stroke with those patients there. So if they just have headache, like intermittent headaches, again, some patients may have worsened migraines associated with this, but against that, really that sudden onset, like worst headache of your life kind of thing, you're really worried about that would definitely warrant discontinuation. Skin hyperpigmentation, again, it's kind of a, could be problematic, may not want to take it because of that. It generally is reversible with some time. And then how about the breakthrough bleeding? That's just normal, right? You'd expect that to occur there. Now, certainly if it's, happening at past 3 months, it may be, something you want to consider switching to a different product, changing the dose of the estrogen or progesterone potentially. But it's going to be a normal expected side effect. And they should know what's normal, what to expect, and then what's going to be abnormal, and should be those things really worrisome. Okay. Which of the following is an abortifacient, but it's also used to induce labor? I've already given this one away, so it should be pretty quick. The oxytocin, nifedipine, misoprostol, or terbutaline. Very good. Misoprostol is the correct answer here. What is oxytocin used for? Induces labor, but typically we're not using it as an abortifacient, right? So typically just used in the labor and delivery setting when you're ready to get that bun out of the oven, right? What else is oxytocin good for? It can help with lactation for sure, and it's also kind of that nice kind of feel good hugging kind of hormone. So if you were petting therapy dogs yesterday, you probably had some oxytocin being released there, right? Nifedipine is good for what? Good for helping with the blood pressure. So if you had someone say preeclampsia, that could be good to help get pressures down. What else could be used for though? Because it's what kind of drug? Calcium channel blocker. What type? It's the dihydropyridine, right? So it's a DHP. What else could it be used for? So it's inhibiting the smooth muscle of the vasculature to try to reduce blood pressure. What other smooth muscle could it relax? The uterus, right? So you could use this as a tocolytic to try to delay labor. So that could be a good drug there. And then terbutaline could be used as what type of drug? Terbutaline sounds a lot like, I guess it doesn't sound like that. Well, so think about breathing, think breath, think asthma, think albuterol, right? So again, they're both beta-2 agonists. So terbutaline and albuterol, they're both beta-2 agonists, cause smooth muscle relaxation in the respiratory tract. Can also do the same thing there on the uterus as well. So terbutaline is a good tocolytic, nifedipine is a good tocolytic. Typically, if you're like sending a patient home, nifedipine is pretty common when you're going to see them used there, because again, it's an oral tablet, they can take it no problem. If they were in the hospital or something, terbutaline might be used a little more frequently. Very good. Which med is indicated for DVT in the post-operative period, say after a hip replacement? Use enoxaparin, sub-Q, warfarin, PO, aspirin, PO, alteplase, IV. I would say they get a DVT after taking an oral contraceptive. Same thing would apply. Very good. Enoxaparin is what type of drug? Low molecular weight heparin, fractionated heparin, right? Good for acute treatment because how does it work? Works the antithrombin 3 to inhibit which factors? 10 and 2 are the big ones, right? But more preferentially with the low molecular weight heparin, it's going to be focusing more on factor 10, right? If you get even shorter than that, that's when you get things like apixaban, rivaroxaban, fondaparinux. Those are all just strictly 10A inhibitors, but enoxaparin still has some 2 activity as well, right? Good for acute treatment because again, it's inactivating factors that are already there causing the clot, right? Aspirin PO, that'd be good. Nah, not really, right? It has antiplatelet effects, but it's not anticoagulant. Okay, so it wouldn't do anything to the clot that's already formed there. How about warfarin? Why would that not be good? Remember, it takes too long to kick in. It takes a few days because how does it work? Stops production of clotting factors by inhibiting which? Vitamin K. Good. So it takes a few days for it to really kick in. Remember, when you initially put a patient on warfarin, they're hypercoagulable for the first few days, right? Because you start to lose a few of those anticoagulant sort of proteins, like protein S and things like that. So you could bridge someone, you could go from enoxaparin, start them on that, and then bridge them to warfarin. That one you could certainly do. But you would not want to use that for the acute treatment. Now, I would tell you that some of the new 10A inhibitors are starting now to be used for acute treatment of DVTs and things like that. So if you were to, say, go to the ER with a DVT, they might actually just give you a pill and you're anticoagulated, which is really nice because you don't have to worry about being on a heparin drip and all this other stuff, right? When would we use alteplase? It's like a massive PE. They're like hemodynamically unstable. If they have stroke potentially, or ischemic stroke, not hemorrhagic, obviously, that is going to be working as what? How does it work? It's a clot buster. It's thrombolytic. How it works? Activates fibrinogen, right? It's tissue plasminogen activator. So by activating tissue plasminogen, it's going to convert and break down fibrin, essentially, right? All right. Fibrinolytic is another name for it as well. Very good. Which of the following is not a common adverse effect seen with hydromorphone overdose? Would I not expect to see? Lethargy, hypertension, respiratory depression, meiosis. First question you ask yourself, what the heck is hydromorphone? What drug is that? Very good. Hypertension is not expected to be seen with hydromorphone overdose. What is hydromorphone? What type of drug? It's an opioid, right? It's going to be working on those mu receptors. It's an analgesic. So, what is kind of the trifecta of things you expect to see with an opioid overdose? See respiratory depression, CNS depression, and meiosis. You think meiosis. Now, do you have to see meiosis? No. Sometimes patients which don't have meiosis seen with it. Certain opioids do not cause meiosis. So don't use that as it's not, you don't want to use that as the one thing to hang your hat on as far as making your diagnosis, right? The best way to determine if someone had overdose on an opioid is what? Give them naloxone. And if they wake up, that tells you right there, right? So again, a lot of times I'll have patients or I'll have providers be like, well, I don't think it's an opioid. They don't have the pinpoint pupils. You don't have to see that, right? So give them a dose of naloxone, see if they wake up, and if they do, then that's your answer right there, right? Very good. Typically, if you see, would you see hypotension then with a hydromorphone overdose? Not typically, right? You may have maybe a little lowering of the blood pressure, but nothing very significant there, right? It's really just the CNS and respiratory depression are the big things you're going to find with those patients. Okay. Which of the following NSAIDs is preferred in a patient with a history of GI ulcer? And it's not what you think. Is it ketorolac, naproxen, ibuprofen, or meloxicam? Which would be preferred? So you order Celebrex, but then the pharmacy calls up and says, oh, we're on national shortage, you guys pick something else. Very good. Yes, meloxicam is actually nice because it's not as selective for COX-2 as something like Celebrex is, but it has some selectivity, right? So it could be preferred. If maybe a patient's not a good candidate for Celebrex, or whatever the case may be, meloxicam is a good option there, right? Naproxen, ibuprofen, those are not going to be selective. Toradol, not selective at all. Also, it's really, really rough on the stomach. So if I had a history like that, I would not want to give them Toradol. Again, that's why we limit Toradol usage to how many days? No more than 5 days, right? Because you worry about the ulcer risk getting higher, that gastric erosion occurring. Where do you see Toradol being used most often? ER, really inpatient anywhere, right? Anywhere in the hospital, because it's very good because it is an IV NSAID. There's other options, but that's really the go-to. And it's nice because it's opioid sparing, right? So again, if I have someone coming in, let's say a femur fracture or something like that, I can give them a dose of Toradol. It's going to help with the pain and work in conjunction with something like an opioid. And I typically need less opioids in general, right? All right, which agent can be used as a prokinetic in patient with gastroparesis? Use cannabis sativa, sodium bicarb, esomeprazole, or metoclopramide. Very interesting, yeah. So cannabis sativa, not necessarily prokinetic, but it is pro-appetite, right? It's going to cause appetite stimulation, so you're going to want to eat more. But it's not necessarily a prokinetic or in that way, right? Sodium bicarb, no, it's used more as what? As an antacid, right? Esomeprazole, PPI doesn't really have any prokinetic effects. However, metoclopramide does, right? So it's going to stimulate further movement, further peristalsis in the GI tract. What else does metoclopramide do? Anti-emetic, right? So it's good from that standpoint. So it's an anti-emetic. What else can it do? Yeah, you can see tardive dyskinesia. You can see things like extrapyramidal side effects with metoclopramide, right? Because it blocks what receptor? D2, right? Because remember, like, dopamine is important for nausea and vomiting. By inhibiting that, you also get good antiemetic actions. That's, again, why metoclopramide is pretty effective as an antiemetic, but it's also good as a prokinetic agent there. Very good. What is cannabis sativa? Well, no one's like, I don't know what that is. It's marijuana, right? There's a very funny scene in The Office, the U.S. version, where I saw a GIF of that on Reddit the other day, and it was very, very funny. It's a memory loss drug. How'd you know? You have no idea, because you have memory loss. Right? Anyway, and then Creed knows exactly what strain it is. Yeah. Go look up the scene. It's very good. Very funny. Anyway, which agent is the best treatment option for pregnancy-related hypertension? Use candesartan, furosemide, methyldopa, or ramipril. A good option here. Yes. So why are candesartan and ramipril not correct? These are super teratogenic. You do not want to. This is category X for those two, right? And again, it is a category X because certainly someone having eclamptic seizures is very bad. You want to get the pressures down. But there we have other drugs that are better than we can get. You don't have to use those essentially. So candesartan is what type of drug? ARB, right? It's an angiotensin receptor blocker. Ramipril is ACE inhibitor, right? So both of those would be contraindicated. Cannot use those. Furosemide could be okay if they have their fluid overload, but that's usually not going to be the best treatment for hypertension there. However, methyldopa, what does that do? Works a lot like clonidine, right? So against the sympatholytics, it's going to decrease release of things like norepinephrine. It's going to help to get the pressures down there, right? What else could we use? Beta blockers are good options here. So like labetalol is a really good one because that has some alpha blocking activity. What else? Nifedipine could be used potentially. Calcium channel blocker could be potentially used. Not found to be teratogenic, right? Now, nifedipine, what side effect could it cause that might be already occurring in a pregnant patient? It gives you constipation, right? It's like a worse than that. So typically don't see it with something like a beta blocker, right? So again, kind of think about what the patient is experiencing and kind of choosing your drug based off of that. Again, if they're having premature contractions, that's why nifedipine can be a really good option there. Something like labetalol really wouldn't manage that because normally, what do we do with the beta receptors to stop contractions? You want an agonist, right? You want something like a beta 2 agonist like terbutaline. So beta blockers is just going to impede that. Okay, so kind of think about what else is going on, and we'll give you your answer. Okay. Which of the following, this is our last question, has the potential to cause physical dependence and addiction? Could it be tramadol, codeine plus acetaminophen, morphine, or methadone? Which ones can cause physical dependence and addiction? If you're taking chronic opioids, what's guaranteed to happen?
How many of those are correct?
I don't know. You gotta find out. It's a good one to end on, though. Right, physical dependence is going to happen 100% of the time in patients taking chronic opioids. Is addiction going to happen 100% of the time? No, it is not. But yes, all four answers are correct because any opioid can cause physical dependence and potentially addiction, right? Tramadol, even if it's a partial agonist, used to be non-controlled substance. Now it's C4 because we realize that there is some abuse potential to it. You can see that physical dependence and addiction. So any of them would be correct here. Which one do you think is the most addictive? It depends, right? It can depend on the dose, depends on the chronicity, etc. You know, some people feel that when you have high peaks of the drug, like you get better dopamine release there, and it causes more of an addictive sort of a high associated with it. So, for instance, if you inject a dose of heroin, you get a very high peak effect. You get a lot of dopamine out of that. That's why I always say, like, you know, you're always chasing that first high they got, because they never really get that same sort of dopamine release. So some people feel that the short-acting, very intense sort of acting medications tend to be a little bit more addictive than something like methadone is longer acting, but really can happen with any of them. So just note that. So anyway, so our winners, we have SP. Where's SP? Fantastic. Very good job. Your free answer is
F.
not F. No, never F. B. Okay. Anyway, DH. Very nice, very nice. And then last place for the win, you came in third place. You didn't win. That's okay. Like they say, second place is just what?
First loser.
No, it's a glass half empty. No, there's second place is just second place. No. Yeah, if you're not first, you're last. No, there's second place, third place, fourth place. All right. Any questions I can answer? So check the Linowit real quick. Just to make sure there's no extra questions here. All right, let's see. I think there's a new question. If a patient requests a non-hormonal IUD, isn't there a copy? We talked about that one before. Can you OD on birth control pills? I mean, you can overdose on anything. I mean, oxygen and water can be deadly if in a big enough dose, but it's very unlikely. Probably just get a lot of GI upset and just throw it back up. Now, which ones would be potentially really dangerous? What could you include in a birth control that could be dangerous? Iron, absolutely. Iron can be really, really deadly. So yeah, you could potentially see an issue there. Once you ruled that out, though, it wouldn't be a big issue. What effect does OCP have post-pregnancy and lactation if the woman is breastfeeding? Typically, you're going to find that it's safe to use together. They don't really have any issues there. It doesn't necessarily inhibit lactation by any means. Because again, you see things like oxytocin, prolactin, and whatnot are going to be more involved with like the breastfeeding aspects of it. But I don't really see any issues with that. You don't really have to worry about any extra hormones going into the baby or anything like that. It's relatively safe. Anyway, any other questions? If not, I release you, and I will see you all next time.